Welcome everyone to DSF's the first of our fall webinar series for 2026. We will be talking to you tonight about insurance. The title is Insurance 101, Understanding, Accessing, and Advocating. I'm Shannon Cloud. I work for DSF as Patient Advocacy Director and also have a daughter with Dravet syndrome. And joining me will be Gloria Rodriguez, who is our Health Equity Corner coordinator and also has a daughter with Dravet syndrome as well. We are glad that you all joined us tonight. We will do our best to impart our knowledge with you about the crazy world of insurance. I'm sure a lot of this information will be things that you already know. Hopefully, you'll learn some things along the way. Maybe there's some parts of insurance that were things that you were not aware of because it's not something that your family personally is dealing with. But our goal with this webinar is really to equip you with the information you need to understand insurance, better understand how to advocate for your child or loved one to ensure that they're getting the coverage and treatments that they need. So starting off, what is insurance? The official definition here, a practice or arrangement by which a company or government agency provides a guarantee of compensation for a specified loss, damage, illness, death, in return for payment of a premium. So I think most of us think of insurance in terms of our insurance on our home, insurance on our car, right? If we get into a car accident or something happens to our home, we have that insurance plan so that we are not going to face the total burden of the loss on our own. So we're essentially doing the same thing with our bodies, right? With our health care. You hope that you don't need insurance. We all should have it. We know it's not always accessible to everyone like we would like it to be. But the reason we have insurance is so that if we do face a healthcare crisis or something catastrophic happens, that we know that we can get the healthcare that we and our loved ones need. So there's lots of different types of insurance plans that are out there. Kind of the big umbrella way of looking at it is that there's private insurance and there's public insurance. So private insurance is private companies who, ultimately their goal is to make money, right? They are, doing this as a for-profit business. And then public insurance, which means that it's run by the government. So, in those cases, we would hope that they totally have our best interests at heart and that it would be accessible to everyone. As you will learn through this discussion tonight, that's not always the case. But that's really the two different overall types of insurance. So as far as private insurance goes, what most of us think about is typical commercial insurance, which would be a private insurance company. Often you get these plans through an employer or the employer of your spouse or partner. Or in some cases, rather than an employer, you could actually go purchase the plan on your own directly from the private insurance company. The health insurance marketplace came to be as a result of the Affordable Care Act passing, which most of us know as Obamacare. This is essentially private insurance, but the states set up a means of accessing this insurance from private companies. So you're essentially, shopping for the insurance from the private companies, but doing it with public assistance. Medicare is the first of the traditional public insurance companies. It's what we typically think of. The magic age of 65 is when we become eligible for Medicare. There are exceptions to that rule, though, where people that have a specific disability or health condition can potentially qualify for that earlier. It is run by the federal government using federal funds. Medicaid is another type of public insurance that is typically low income people that qualify for Medicaid. The only difference with it is both federal and state funds that are contributing to Medicaid, and it is run by each individual state runs their own Medicaid program, but using both their own funds as well as funds they get from the federal government. CHIP, which is the Children's Health Insurance Program, is another form of public insurance. It is intended for kids and women that are pregnant that make too much for Medicaid, but can't necessarily afford private insurance. So it's kind of somewhere in the middle. And it's the same thing where it is run by each state they run their own plan, but the money comes partially from the federal government as well. And then TRICARE is something that we won't spend a whole lot of time talking about tonight, but that is coverage for active duty military members and their families. The Department of Defense provides those plans. I know we do have some families in our community that do utilize TRICARE, but it's not something that we personally know a lot about or will spend a whole lot of time talking about. All right, before I dig a little bit more into the types of insurance, like we put this slide at the very beginning on purpose because it does not matter what type of insurance you have a right to appeal. So if you get denied for any reason for a treatment, a therapy, whether it's a medication or that you want to see a certain doctor or have a certain procedure, you can appeal that decision. It doesn't matter whether you have private insurance, whether you have Medicaid, Medicare, CHIP, whatever, you can always appeal. So if you get a denial, don't assume, well, that's it, they're not going to cover it, and just, walk away and say, I'm not going to fight for it. You can file the appeal. Different plans have different processes in order for you to do that. Getting your doctor involved can certainly make a difference. If the appeal is denied, you still don't have to accept that answer. There's always a way that you can escalate to a higher level to get somebody to look at it again and say, you know what, maybe we should be covering this service or this treatment for this patient. Appeals do take a lot of effort, but it is widely known that the majority of times that people appeal a decision, it does end up getting overturned. Obviously, that's not always the case, but I think a lot of times the insurance companies think it's easier for them just to say no and hope that you'll accept that answer, and then they get out of having to cover it. So the important thing to remember is that you should always fight those denials and appeal or do whatever you can to make sure that your loved one gets what they need. So a little bit more about private and commercial insurance. So as I mentioned before, it's typically through an employer, but you can go purchase it on your own. The advantage to doing it through employer is that they typically are paying a portion of those premiums for you. Some cases it could be half and half. Some companies are more generous and they pay a larger chunk of it. There's some companies out there where they pay the entire premium on your behalf, but I would say that's pretty rare as healthcare costs have gone up so much. There are different types of plans that an employer can do. They can self-fund their own plan. So that basically means that everybody that works for that company is kind of in one pool together. The premiums get pulled together, and then the costs for the coverage that is needed for those patients, the treatments, whatever, is kind of pulled out of that money, and they're not, taking the hit of people outside of the company that might have something catastrophic happen. So some companies choose to self-fund in this way because it gives them more control of their plan in terms of what they're offering and what they're willing to cover. But more often, companies are actually joining with a larger group of companies, and that minimizes their potential for risk because it's, across a wider base of people and not just about their own employee base. We wanted to mention that it is important to know how your plan works because there are times when if something gets denied, you can go to your employer or your HR department and explain to them. And if you have a pretty good understanding of how your plan is set up, they may be willing to, bend the rules and make an exception for something, especially if you work for a great company that likes to take care of their people. When an employer sets up the options that are available to their employees. They'll work with whatever insurance company that they have chosen, and they will decide what types of plans to offer. Sometimes you get multiple choices, and sometimes you're stuck with whatever the one plan is that they're offering. But they have the ability to set up like what the deductibles are going to be, how much they're willing to cover, how much you have to pay on your own. And then, as I mentioned, some companies will only offer the one type, but sometimes you get choices during your open enrollment period where you're able to choose the plan that works best for you. And then some of the most common insurance companies that most of us have heard of: Aetna, Blue Cross Blue Shield, United Healthcare. And then there are different types of plans when you have private insurance. So, I mean, a lot of times you hear these acronyms thrown about HMO, PPO, and I think a lot of us don't really understand what those mean. And it really does come down to the way the plan is set up in terms of how you access the health care and what's covered. So, with an HMO, there is a network and if you want to see a specialist, you always are going to have to go to your primary care physician and get a referral. You can't just say, "Oh, I want to go see the cardiologist because I'm having this problem," or "I want to go, see the neurologist," or whatever. You are always going to have to go through your primary care physician to get those referrals. And if you want to see a doctor that is out of that network, you may end up having to pay. PPOs typically have a bigger network of doctors, and you don't need to get that referral. So it gives you a lot more flexibility in terms of selecting the care that you want, but you're going to pay higher premiums. Um, an EPO and a point of service, those are both kind of a combination, kind of somewhere in between the two. Again, it often comes down to, whether you want to see a specialist without a referral, and how much you're willing to pay for your deductible and what coinsurance you have to take on. And then lastly, high deductible health plans. These plans are kind of interesting. The premiums are typically really low, but you are going to have a high deductible. So you could end up paying a lot more on one of these kinds of plans, except for preventive care. That is always covered at 100%. So these plans are really ideal either for a very healthy person who does not expect to really have to see specialists or have anything major come up, because you're paying those low premiums and then you're not really ever paying anything else. Or they are helpful in some cases for someone who knows that they are going to have a lot of healthcare expenses for the year because you're paying those low premiums. But then once you've hit that deductible, everything is covered at 100%, which is a nice thing. And then the health insurance marketplace. Again, this was a result of the Affordable Care Act, which came to be in 2010. So the intent behind this is to make sure that healthcare is accessible to everyone that lives in the United States, regardless of income, whether you have an employer that offers a plan or what. That was the goal behind it. Um, you get to pick the plan. So when you go onto the marketplace for your state to look at the options, you get to pick what you want in terms of whether it's an HMO or a PPO or what type of plan it is. So you can kind of like shop those different options to figure out what works best for you. They often do have high premiums and deductibles. The intent when this came to be was that there are a lot of tax credits and subsidies that are available, particularly those for low income families and individuals. Again, with the goal being to keep it so that it is available for everyone. Unfortunately, last year, a lot of those tax credits and subsidies were eliminated. So for the plans starting in 2026, the costs went up significantly. So I personally know some people that have their insurance through the marketplace. They were already paying a lot, and for 2026, their costs went up even more because they were no longer eligible for some of those subsidies that helped before. As I mentioned, these plans are through private insurance companies, but you have the ability to go on the website for your state. Some of them run their own states, some use healthcare.gov, and you can pick the plan that works best for you. The key point behind these plans is that there are 10 essential health benefits that must be required in all of these plans. So the main ones, obviously, like prescription drugs, hospital visits, maternity care. Those are the things that all of these plans are required to cover. So it is possible to have multiple insurance plans for a particular individual and especially in a family. So I would say the most common example that's probably the case for a lot of families in our community is that the parents and the rest of the family are covered solely on a private insurance plan or through the marketplace, but a loved one with Dravet or some other significant health challenge may have Medicaid through a waiver. So that's a pretty common scenario for a lot of our families. Um, you could have a family where there's older members, they're on Medicare, but Medicaid or private insurance is who the children of the rest of the family are covered by. It is possible, even in a family, to have multiple children that are covered in different ways. Again, a child with Dravet could have Medicaid, but then the rest of the kids in the family might be covered under private insurance, or they might qualify for a CHIP plan. The key thing to know if you have both public and private is that the private insurance is always going to be considered the primary. So, um, any doctor's office should know that they bill the primary insurance first, and then whatever is left that the primary doesn't cover would go and get billed to Medicaid. So, if you have a deductible, whether it's a $300 deductible or a $5,000 deductible, you typically are going to have to always meet that deductible on your private insurance before Medicaid really starts picking up anything else in terms of the cost. Um, in some cases, if you have a copay, Medicaid may pick up the copay for you as you're still working on meeting your deductible on the private plan, though. If I've personally have found like sometimes that at CVS pharmacy, they may submit something and I realize after the fact that if I don't end up paying what I was expecting, it's because they ran it through one insurance and not the other. So it's really important to always make sure that you are confirming that they are billing the private insurance first and then submitting to Medicaid so that you don't end up paying any more than what you have to. You can always check the EOB statements that you get from your insurance company so that you can see exactly what was being billed and what was covered so that you make sure that it's what you were expecting. All right, now I'm going to turn it over to Gloria and let her talk a little bit about why Medicaid is so important for our families.
Thank you, Shannon. So why does Medicaid matter for Dravet families? I'm sure I don't have to remind all of you as caregivers and parents like me and Shannon how important it is to have the best coverage possible. Our kids, our loved ones have highly complex chronic health conditions and they require around-the-clock care. So Dravet and other rare disease community, they really rely on Medicaid for access to coverage for diagnosing, for treatments, for home health care, for medical equipment, for caregiving services, either through a waiver or through regular Medicaid. In some case, Medicaid is the only insurance program that provides the comprehensive care that our loved ones need. And Medicaid may provide easier access to existing or new rare disease treatments. They're required to provide coverage for things that private insurance companies do not. So if your private health insurance won't cover something, and you get a denial, you have to get a denial so that it will go over to Medicaid for coverage, hopefully at that point, if you have it. Even if you have good insurance, it's a good idea to figure out how to get Medicaid for your child because it may pick up the remaining costs or provide easier access to treatments. So understanding Medicaid and CHIP. So they cover different things. Medicaid and CHIP, they're both joint federal and state programs, like Shannon mentioned earlier. They help cover medical costs for people with limited income and resources. So Medicaid is low or no cost for low income individuals at any age, right? As long as they meet the income limits. CHIP is for children under 19 years old and whose families earn too much for Medicaid coverage. The federal government has rules that all state Medicaid programs have to follow, but it can be confusing because every state Medicaid program goes by a different name, right? So like here in Texas, ours is Star Kids. So every state could have a different name. So it can be confusing. You can find the name of your own state's plan at the healthcare.gov website. Eligibility and benefits can also vary from state to state, and they're based on different characteristics like your age, your loved one's age, your income, their disability status, or pregnancy status. Okay, what services are covered by Medicaid? Medicaid programs have both mandatory services that have to be covered and optional services that a state can choose to cover. Mandatory services include things like inpatient hospital visits, outpatient hospital services, home health services, rural health clinics, things like that. States also have to provide a more comprehensive set of services known as early and periodic screening, diagnostic, and treatment, EPSDT. Can't say that 5 times fast. Anyway, it's a benefit for children under the age of 21. Optional services are things like dental care, eyeglasses, physical or occupational therapy, and variations in different prescription drug coverage depends on the state. And states are not required to cover prescription drugs as of now, but all states so far have elected to include a drug benefit. Some state Medicaid programs, though, they can have limits and specific criteria for the coverage, like how much they'll cover, or they'll make you go through a prior authorization or step therapy. Okay, what is Medicaid expansion? The Affordable Care Act that Shannon talked about earlier, it gave states the option to expand their Medicaid program to adults with incomes up to 138% of the federal poverty level, which equals to $36,777 a year for a family of 3 people. For that expanded population, 90% of the cost was paid by the federal government, while the states only had to pay for 10%. For the regular Medicaid population, the cost is split 50-50. So there was this expansion where states didn't have to pay as much. Today, 40 states and DC, the District of Columbia, chose to expand their Medicaid eligibility, while states like my own and Shannon's chose not to accept that expansion. And that meant that more than 21 million people gained coverage through Medicaid expansion. Medicaid expansion is an example, just one of the examples of how federal policy can change a state's Medicaid program in so many different ways. HR 1, or the One Big Beautiful Bill that was passed mid-year last year, it requires states that adhered to this expansion. It required them to implement additional work requirements specifically for the adult expansion population. Waivers. Okay. A Medicaid waiver program is a special set of services that each state can provide after the government has approved their program. So a waiver program usually puts specific, they're usually specific to a certain population or a need or a service or what might not be included in the typical benefit. Waivers can cover home and community-based services, HCBS, for individuals and children in foster care who may not have otherwise been eligible. And many Dravet families like ours qualify for this expanded coverage programs where requirements like thresholds for your income have been waived. So when states have limited budgets for this type of funding, these waivers become vulnerable to reductions because waivers are considered optional. States don't have to provide any waivers at all. So a 1915 waiver is a certain type of waiver program. It allows states to provide home and community-based services and long-term services and supports. For so many of our patients and our families, our loved ones, these waivers are a key resource to make sure that our families stay together, our loved ones stay home, and they still get provided a very high quality healthcare service at home instead of an institution. There's Katie Beckett waivers. And they could be called something different in your state, but a Katie Beckett waiver, I think it was back in the 80s. Um, it's a type of 1915 waiver that provides long-term care benefits for children up to age 19 who qualify for institutional care but can still live at home. The Tax Equity and Fiscal Responsibility Act, TEFRA waivers, they're designed to help children with disabilities by excluding the income of the child's parents, allowing the child to qualify for services independently of their family and having no income. 43 states offer the Katie Beckett waiver or TEFRA waiver. Again, my state is not one of those. There's 1115 waivers. These allow states to test new or experimental programs and approaches to their Medicaid and CHIP programs that go beyond what is typically allowed. So work requirements for able-bodied adults are an example of an 1115 waiver. These recent changes in HR 1 have ordered the requirement into law. So non-expansion states would not be subject to HR 1, but they can still apply that work requirement through an 1115 waiver, even if they don't have to. So an example, in Georgia, it's a Georgia Pathways program. It was created by one of these 1115 waiver programs requiring adults in the state to work to receive benefits. There's another one in Arkansas, a program, but it was stopped by a federal judge due to a high level of disenrollments because of it. Arkansas providers reported that most vulnerable enrollees would most likely face barriers in complying with those requirements, which were people with disabilities or were homeless. How does HR 1 change Medicaid policy? Shannon, do you want to take over here?
Sure. So, as most of you know, HR 1 was also referred to as the One Big Beautiful Bill Act that passed in June of 2025. Um, it had a lot of different things in it that have a lot of implications on healthcare. So most of that centers around changes to Medicaid in terms of who qualifies and what the rules and requirements will be. Um, the key takeaway is that HR 1 cuts back on how much the federal government is going to give the states for Medicaid. So we have explained a lot about how Medicaid works and it's run by the states, but they get a certain amount of money from the federal government. That cost sharing is going to shift. The federal government is going to be sending less money to those states. We know that that will result in states changing a lot of their programs. Again, as Gloria mentioned, some of that stuff is required, right? They have to provide certain services, but a lot of the waiver programs and other things are not required. So, unfortunately, the estimates are that there will probably be about 10 million people that will end up losing Medicaid coverage completely as a result of these changes. Their goal is that over the next 10 years, the federal government will spend $900 billion less on Medicaid than what they would have spent if things continued the way that it has been. Um, you'll hear a lot about the different changes that are happening, and they very intentionally implemented these changes gradually, which on the one hand is a good thing because it means that a lot of people aren't feeling these hits immediately. They have some time to kind of plan and react. But I do want to mention that a lot of the intention behind the timing was so that the changes that are going to hurt people the most are happening in January of 2027, which is conveniently after the midterm elections that are happening this year. So I think there are a lot of people that probably don't realize that some of these changes they've been hearing about are going to impact them and they just haven't yet. One of the biggest changes is for people that are covered by Medicaid expansion in those 40 states plus DC that have expanded Medicaid. They are putting new rules in place about with work requirements that those people now have to have a job for at least 80 hours a month. In some cases, like job training or volunteering or school can also meet that requirement, but they are going to make it much more difficult for those people in order to continue with their coverage. Another big reason that it will be more challenging is because instead of once a year having to provide the proof that they still qualify, they now have to do that every 6 months, which obviously for those of us that have to constantly prove that our kids with Dravet haven't magically been cured and they still need these coverages, the idea of having to do that more frequently is very frustrating when it's already such a burdensome process. Um, and then just to point out that, a lot of people just assume that everybody on Medicaid are just lazy people who don't work. And that's not the case at all. 64% of adults on Medicaid do work full or part-time. Obviously, people who are caregivers or people who are truly disabled themselves um, are not able to work. But unfortunately, these work requirements are going to end up disenrolling a lot of people from Medicaid who really are in a position where they can't afford private insurance on their own or don't have a way to get it. And the expansion had been a really great thing for them to be able to access Medicaid coverage and have health care. And a lot of people are going to be losing that. Um, so I kind of touched on this already a little bit, but the biggest impact of HR1 is that the states are going to have less money. And one of the ways that they're doing that is that there were certain rules in place already that are going to change in terms of provider taxes and the amount of state directed payments. And so these states are going to end up with less money. Um, State directed payments are a way for state Medicaid agencies to direct managed care organizations to make specific provider payments to support state policy goals, such as improving the quality of care, enhancing access to services, or addressing priority health care needs. So the fact that those are going to be limited going forward are going to make it really hard, especially for rural hospitals to survive, because that's a lot of what they have relied on, knowing that rural hospitals often have a very high percentage of Medicaid patients that are coming. Um, I know for where I live in Georgia, that's definitely something that I'm already hearing about is how rural hospitals are going to be very impacted by these changes and are at risk of closing. The last thing that any of us need is to have hospitals that may be the first line for us when our child has a seizure not be available simply because of these Medicaid funding changes that are happening at the federal level. So, what are the states going to do about this? Again, I know I keep saying this, but the key message is they are going to have less money coming from the federal government. And so, a lot of them are already cutting back on their state budgets, knowing that this is going to be coming. So, again, certain things are required, they can't cut back on. But the Medicaid waivers for things like home and community-based services, the waivers that allow our kids often to have Medicaid coverage regardless of parent income. Unfortunately, some of those programs may be on the chopping block as states have to figure out how to manage their budgets with less money. We know that there are states out there that will do everything they can to ensure that those programs do not get cut. They'll pull money from other places in the budget. They'll figure out a way to make sure that their most vulnerable people are taken care of. Unfortunately, some of us live in states where our communities are probably not as big of a priority, and we likely are going to see cuts happening. I know, I've talked to several parents in different states that are already seeing the impacts of these changes in their states where, basic medical equipment and therapies and things that had always just been covered before are now being drastically reduced. So, this really does create an opportunity for all of us to advocate and try to speak up on these changes and how they're going to impact us. Let me go back there. So I think I have a slide about that at the end too. I can't remember, but we do have a lot of we're trying to empower our community, right, and educate people and make sure that everybody's aware of the changes that are coming and how it could potentially impact us so that we can get parents and our other people in our circles involved both at the state level and the federal level to advocate for policies and legislation that will protect our kids and our loved ones with Dravet. All right, so we added a bunch of pharmacy information to this presentation. And so Gloria is going to go over it. It's a lot. We will send out the slides after so you can read through it because I don't know how much time we'll have to dig into this, but we really wanted to make sure that you guys understand how things work when you're getting your prescriptions from your pharmacy, and that you understand the best way to ensure that, things are getting covered. So, Gloria, take it away.
I'll go as quickly as I can. So Pharmacy 101 for anyone that might not be aware or are new to insurance coverage when it comes to a pharmacy benefit. Medications can be covered either under their medical benefit or their pharmacy benefit with different coverage criteria, different out-of-pocket costs. Usually it depends on the way the drug is administered. Some insurance plans have a separate plan for medical and for pharmacy, so pay attention to that information on your ID card. Also, many insurance companies may contract with another pharmacy, like United Healthcare uses OptumRx, Aetna typically uses CVS Caremark, etc. Things like that. It should be on your card. Read your plan documents to make sure you understand your plan's cost coverages, like your deductible, your copay, your out-of-pocket maximum, things like that. Make sure the medication is included in your plan's formulary, which is the covered list. Formulary plans are usually, those decisions are made in July of every year for the next year, for your open enrollment. You can request an exception for medically necessary drugs that might not be covered. Use a preferred network pharmacy to minimize your out-of-pocket costs. And sometimes a mail-in order can really be substantially cheaper, or even a preferred local retail pharmacy. Some insurance plans will will require a prior authorization from your doctor, or for certain medications, it's usually once a year. Your doctor would have to show that the drug is medically necessary before the plan will even cover it. Often, the prior authorization will expire after a certain time. Usually it's a year, and the insurance company will require a new one every year. Different insurance companies and plans and state Medicaid programs, they all have different rules for co-pays and different cost sharing. So the cost of a drug can vary significantly. All Medicaid plans, they currently cover prescription drugs, even though it's optional for them to do so, but what is covered and the cost may not be the same from state to state. Okay, so what's a specialty pharmacy? Okay, these are pharmacies that are designed to ensure patients receive medication and clinical support that's necessary to manage high risk and complex treatments effectively, like for our loved ones. These medications, they require specialized handling, specialized storage, specialized administration. So examples, Fintepla, Epidiolex, Diacomit, they can be obtained only from a specialty pharmacy. So what's a specialty drug? It's a type of prescription drug that requires special handling or ongoing monitoring and assessment by a professional, and it's relatively difficult to dispense. What is step therapy? Sometimes your plan might require you to try one or more medications before approving the coverage for that medication. This is called step therapy, and some states have laws in place preventing this. So you can check this at this link. Shannon said she's going to send these slides out, the NORD state report card, or you can just Google that or go to the NORD site to see if your state has a law in place preventing step therapy. I know mine does. Brand name drugs. Drugs are sold under the name of the company that made them. They're also protected by a patent. A brand name drug can only be sold by the company holding the patent. Generic drugs are companies of brand name drugs. The generic drug is required to have the same active ingredient, strength, and dosage as the brand name. But it also, but must also be taken the same way. Generic drugs typically cost less than the brand name drugs, are only available after a drug has been on the market for a specific number of years. Now, if your loved one needs the brand name drug, make sure that you communicate this with the doctor writing the prescription, because the pharmacy may try to substitute with a generic form if not otherwise specified on the prescription. I know for my child, we have to have brand name of a certain medication, or we have breakthrough seizures. If you're having trouble meeting your deductibles or your copay amounts for your medication, ask your doctor or your pharmacist if the manufacturer has a coupon card or if there are any organizations that may be able to help. This is what Shannon touched on earlier. And what's next? Advocacy. We need to speak up. We all have a voice and we can advocate for our loved ones and for our families. And because all these changes are going to impact our lives. Shannon?
Yeah, I mean, I'll just add kind of the first point here. As devastating as these cuts are that happened in HR1, it actually could have been even worse if there hadn't been so many people that were advocating so hard to fight against those change. One positive thing that's happened is that while that law passed last year, now this year Congress is working on budgets for the different things, right? They have to implement what was passed in that law. And in some areas, they are actually pushing back and saying, no, we're not going to make some of those cuts that were required in that law in terms of the way that they're funding the budgets and things. So our voices are definitely making a difference, but we do need to keep advocating. Whether it's reaching out to Congress to talk about it. They need reminders about our kids and our loved ones, right? It's real easy for them when they're sitting in their offices in DC and making decisions where, they typically just want to vote on party lines, but they need to realize that these are, families and real lives of the people that they represent that are impacted by these decisions that they are making. A lot of our advocacy from a DSF standpoint is focused on the federal level because, that's where a lot of these changes are happening, and that's something we can do on behalf of the whole community. But so much of what really truly happens to us individually is happening at the state level. And especially as the states are implementing all of these cuts from HR1 with less money, that's where it becomes really important for us to develop relationships with our state legislators because they're the ones that are voting on the budget and deciding how much money is going to go where. And then the Medicaid program administrators as well, like they're the ones trying to figure out how, what are we going to keep? What are we going to cut? What kind of new requirements are we going to put in place? So it really is, a great idea to try to stay plugged into what's happening in your particular state if Medicaid is important to your family, particular if you're utilizing a waiver program. Um,
Can
and
I
then,
add,
yeah, don't be
Shannon?
afraid to,
Not
yeah,
not
go ahead.
only not only everything that you just said, but these budgets are going to put such a strain on states. Like they're going to have to implement a program on how to keep track of who has work requirements, how much are they working, how often are they working, do they what kind of a computer system is going to do this? Is it people? Are there people that are going to do these checks? That means they're going to have to hire more people. They're going to have to spend more money implementing these changes than they would have just keeping the program all together. So that's something to think about as well.
Yes, very, very fair point. That while the goal is to cut 900 billion over the next 10 years, they are definitely introducing some new cost into the equation because of all of these rules and things that have to be implemented. Um, the last point here was, just really hold these people accountable, right? We vote them into office, and it doesn't matter whether we're Republican or whether we're Democrat. It doesn't matter whether they are Republican or whether they are Democrat or independent. They are in these positions of power and making these decisions because they represent us. They represent our children. And so, you can obviously you can send them an email, you can call their office. You can comment on their social media. A lot of these legislators, they spend a lot of time on social media. Even if it's not them posting it, it may be one of their staff members, but they're paying attention. When they put out something on social media that, hey, I voted in support of this or I'm against this, they are keeping track of what their constituents are saying. So if you see, your member of Congress or somebody at the state level, like supporting something that helps your family, comment on their social media and say, thank you so much for supporting that because my child really needs this. Likewise, if you see something that is going to hurt your family, make sure you call them out on that. Like it's okay to let them know and let other people know, because I think so often people do just kind of side with whatever their party affiliation is, and they don't really take the time to think about the real people on the other side that may be impacted. You can go to a town hall meeting, you can talk to reporters. I mean, all of these things are things that really do get their attention, not only for the member again, but also, like I said, just for helping to educate other people who just assume that everybody that depends on Medicaid must just be lazy people who don't want to work and, aren't trying to take care of their families, when we know that's obviously not the case. That is the end of our official presentation. We are available anytime to answer questions. So both of our email addresses are here. Please reach out to us really and truly at any time. And Gloria and I both, any member of the DSF staff, we are happy to help answer whatever questions. If it's an insurance question or something, we may not know the answer, but we can certainly help do some research for you, and help you figure it out if you're not sure where to go or you are encountering an issue of some sort.